The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanek, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Hi, everybody. We are gathered here for the next episode of TMD Demystified, and I am Tony Urbanek. Today's title and topic is why protocol compliance, that is protocol for the TMD device, protocol compliance matters more than the device itself. Why protocol compliance matters more than the device. Now, for those of you who are here for the first time, welcome, and you can catch up with what I have to say by viewing any, hopefully not all, there are 239 priors. This is the 240th episode of TMD Demystified. However, we're not going to bore everyone by going through material that has already been well covered. The point I want to make today, and it is very critical, I think, as I proceed with these episodes, with these articles, with these titles and concepts, it becomes clear to me where the soft spots are in getting both patients and doctors to understand how to treat TMD very simply, very effectively, certainly without surgery, certainly without drugs, certainly without long-term treatment, other than the use of a device and protocol. Now, the problem that I've identified a long time ago, this is not new. What I am going to discuss is it is a new presented concept why the protocol is more important than the device, but the problem has been for quite some time that the doctors and patients think that the device, which is important, which is critical, you can't get the result without the device, but the device simply is a device that decompresses the temporomandibular joint. We'll talk a little bit about decompression here in a minute. But it has to be a device that you can use, that you can talk with, that you can breathe with, that you can drink with. You just can't chew with a device in your mouth. But what the device does is decompresses the temporomandibular joint. But you can't use the device just any old way. You have to know how to use it properly, and that's where the protocol comes in. And then understanding the protocol is very important. If you want to get away from just thinking you pop this thing in your mouth and your pain's going to go away or your ringing in your ear is going to go away, which it's not, it's just by popping the device in your mouth. But some people, some patients have that narrow point of view, and some doctors have that narrow point of view that it's all about the device and you have to modify the device, or one device is better than the other device. Well, yeah, a night guard certainly has no business trying to treat TMD. So yeah, some devices are not good and don't work, but a device that separates the posterior teeth adequately according to a protocol can safely decompress the temporomandibular joint while not allowing any super eruption of the posterior teeth, which is the major concern among dentists if you put something in the mouth that separates the posterior teeth for any length of time. And that has been discussed thoroughly before, and why that is not an issue. But the point is, the protocol and compliance with the protocol is very important. And that is where I have seen now, after treating well over 5,000 people successfully personally, and now we have doctors in 18 states who use the device and protocol in the same manner we do in the practice, and they're getting the same results. And that group is growing, and the number of states is growing. But what I've found out is that the understanding of why the protocol is important and how the protocol works to the effectiveness of the device. Because the device is static. The device is the device. It is made on a patient's models. It is made for a specific patient. But once the device is made, it doesn't change. What does change somewhat is the protocol, depending on circumstances. There's a foundational protocol, which won't keep you in suspense, using the device 24/7 for 2 months, except when you eat, and then nighttime, quote, sleep time, the rest of your life. And that at times becomes modified according to circumstances with the environment and with the patient, and maybe even possibly with the overlying observing and doctor who prescribed the device and follows it along. So let me just get into the meat of this and explain so it makes logical sense. It would be nice, it would be great if you could figure out a way to decrease inflammation within the joint by popping a pill. And there are pills you can pop. Non-steroidals work very good, as I've covered many times before, on decreasing inflammation, but they're only short-termers. They only work short period of time. Then you run out of steam, and the more you take, the more complications you have. Some of them can be extremely serious, and non-steroidal anti-inflammatories do not work on temporomandibular joint symptoms, especially the long-standing symptoms like the non-painful symptoms of tinnitus, ringing in the ears, subjective hearing loss, and vertigo. Those are also significant symptoms for some patients. And then there are painful symptoms, which are frequent and or recurring headache, earache, jaw pain, neck pain, upper back and shoulder pain and tightness, arm, hand, finger tingling and numbness, and various kinds of jaw locking. But it is really the protocol that is more important than just putting in the device according to that standard protocol. And this is the reason you have to understand what's going on with inflammation. And that is one of the advantages I had in figuring this out to begin with, is that I have a pretty good grounding, actually a degree, in cell biology and also gross anatomy. But cell biology, especially with understanding and can read the papers and understand the concepts of what chronic inflammation is all about. But you don't have to be a wizard, and you don't have to have a degree in cell biology to understand it and explain it. So let me explain to you the meat of this the centerpiece of this entire episode. And that is, if you understand how inflammation ebbs and flows, and what creates inflammation, and what allows inflammation to go away, then both the patient and the doctor who prescribes the device and protocol, who monitors the patient through their progress through the system, can understand and actually track what's happening by the results that they see. And it's quite simple. First of all, inflammation is the body's response to damage. And the temporomandibular joint can be damaged by 3 primary causes. There are only 3 that I know about. That is bruxism, clenching and grinding. Number 2, acute trauma of various kinds, especially motor vehicle accidents and whiplash injuries, but there are many ways to damage the temporomandibular joint due to acute trauma. And then the third I've discussed so often and in depth is functional malocclusion of many kinds. Can be many, many different kinds of functional malocclusion, but basically a functional malocclusion that overloads the temporomandibular joint over a period of time. the jaw mechanism and the temporomandibular joint mechanism, and that its relationship to the upper jaw and the middle face is a highly complex system of muscles and teeth and bone and nerves and the endocrine system that goes along with it. And it's not my point to teach that. My point is to teach the fact that inflammation is the body's response to damage within the temporomandibular joint, which, if it does not heal over a relatively short period of time, turns into chronic inflammation, which changes the cellular type and cellular response within the temporomandibular joint, which among many things can do two major things. Number one, it creates a mechanism that signals the muscles that move the jaw, then move the neck, and then move the upper shoulder girdle to get tight. And when that happens, it creates pain because the muscles pull on the periosteum, and the periosteum is where the nociceptors are, and wherever that particular muscle, that particular day, at that particular time, gets the signal to tighten up, it will create pain that can last a short period of time and be very acute, or can last a long period of time and very chronic, can be sharp, it can be dull, it can feel like burning. But the point is, that's the painful mechanism. And if chronic inflammation is allowed to progress over a period of time, it actually creates additional damage within the joint itself, within the joint capsule. And when you start getting loosening of the disc itself, the meniscus, the cushion can be dislocated, causing locking of various kinds and damage to the bone structures within the joint itself, of the glenoid fossa and the condylar head, the ball and the socket, can actually cause bone loss. And we see it frequently over patients who over a long period of time have suffered with inflammation within the joint, turning into chronic inflammation, causing significant damage to the joint, bone loss, which only complicates matter and subsidizes the chronic inflammation, which goes on indefinitely. Now, the one point that is important to understand about inflammation itself in the earlier stages, not the later stages, I'm talking about the first few years or even first few decades, the inflammation is cyclical. The body is a wonderful mechanism for self-healing. And for anyone who would like to study that, there's a lot of material on the internet, and it goes on forever. But just leave it at this, that the body itself is a wonderful mechanism for self-healing, and inflammation is the hallmark of the body trying to heal itself. But inflammation in the earlier stages has a cycle to it. When the inflammation goes up trying to heal, with or without the help of any outside interest, the help of drugs, the help of physical therapy, the help of doctors, inflammation will go up to a certain point, and it will create symptoms. Biggest symptom is pain. We just discussed that. And the inflammation goes up, and the body itself sees that inflammation wherever it is in the body. It can be in the lungs, it can be in the belly, it can be in the mouth with periodontal disease. All your diseases are related to inflammation and chronic inflammation. And then the body spots that inflammation and starts the inflammatory process, healing process, and the inflammation goes down to the point that it feels better. And that's important and critical to understand. And then it feels better for a while, and then the inflammation starts coming back because of the damage. The inflammation gets higher and higher. The body spots that inflammation again, starts to drive it on down with drugs, without drugs, without any outside help, and it feels better for a while. And this cyclical nature of up and down, inflammation going up, body spots it, starts to go down, feels better, comes back, hurts more, stays longer, goes away for a while, comes back, hurts more, stays longer, goes away for a while, comes back, hurts more, stay longer, always cycling, always getting worse, is the hallmark of temporomandibular joint problems. always cycling, always getting worse. And patients go, yeah, that's exactly what's happened. How did you know that? Well, I knew that because I understand the general nature of inflammation. You don't have to know the cell types. You don't have to put big explanations on the cellular exudates, etc. You just have to know that inflammation goes up and down, and as the inflammation goes up and down, the symptoms go up and down to the point where after a while, this process can go on for decades. I've seen literally thousands of patients who suffer this for decades to the point where it actually stops going down. And instead of cycling, the patient will say, well, it cycled for the first 20 years, and now it just hurts all the time, never goes away, constantly. That's where up here, way above where you can see. That is consistent, and the patient's eyes get big and they go, how did you know all that? And it's, well, mainly because I studied the problem, but more importantly, I listened to the patient's histories. So the protocol, which is well understood of why you do this protocol, when you understand how inflammation cycles and that you have to decompress or unload the temporomandibular joint consistently over a long period of time. If you allow the joint to be overloaded, even after treatment or during treatment, you can stimulate more inflammation, which is going to create more symptoms. So the protocol is designed very simply the first 2 months, and 2 months is over most patients adequately to do 24/7, except when you eat, have it in your mouth. And so you have totally unloaded this joint. You have totally decompressed this joint for the most part for the first 2 months, which allows the inflammation to go down, go down, go down, go down. Cellular response gets better, inflammatory response gets better, the exudates get less and less damaging, and then after 2 months, go to a nighttime only use, nighttime meaning sleep time, because you can't wear the device 24/7 indefinitely. Then you will get super eruption of posterior teeth. But for the first 2 months, because it's only 2 months, and this is in adults only, children is different. I've mentioned that many times before. But in adults, 2 months with the patient taking it out at least once or twice or maybe 3 times a day or maybe more to chew something, you're not going to get super eruption of posterior teeth. But you can't do 24/7 forever because eventually you will get super eruption of posterior teeth. That is why you go to nighttime. And then some patients do need to wear it more than nighttime and can wear it an additional 6 or 8 hours during the day, depending on their circumstances. But what we find is 85% of our patients only need to use the nighttime, and 15% find they need to use it more during the day, an additional 4, 6, 8 hours a day, especially when they're stressed, and the usual and customary statements are, when I'm in traffic or when I'm sitting on the computer, I put it in my mouth. That's technically what we see. But it's very easy. But my point is, why are you doing that? What you're doing once you get past the 24/7 is doing enough disocclusion, enough decompression, enough unloading of the joint to keep the inflammation down. So I hope that's clear. You just what you're trying to do is just keep the inflammation at bay, at a point where it doesn't generate the signals of the muscles to tighten up or generate enough inflammatory fluid to change the composition in the middle ear, which brings to mind how it gets into the middle ear through the petrotympanic fissure, from the temporomandibular joint into the middle ear, through the petrotympanic fissure, causing tinnitus, subjective hearing loss, and vertigo, the non-painful symptoms. So when the practitioner, the provider, and the patient, especially the patient, understands why they're doing what they're asked to do, which is keep the device in your mouth for the first 24/7 for the first 2 months, allowing the long-standing chronic inflammations to start to subside as the chronic inflammation subsides, and to the degree that the chronic inflammation subsides, and at the rate at the chronic inflammation subsides, you will see decrease in these symptoms. It's not an all or none. It's not like a light switch. It is a gradual decrease, and each of the symptoms has its own rate of decrease. They all don't go down simultaneously. But these are just well understood phenomenon that occurs as the inflammation decreases. And if it's understood what to expect by both provider and the patient, then they more often than not will use the device correctly rather than come up with their own protocol, which we have had to deal with for 15 years. Patients decide they want to use it how they want to use it, and then they don't necessarily get the good response. What I have seen is they get some response. Had a patient yesterday who fully admitted that, nighttime only did pretty well, but sometimes she felt she needed to do it during the day, and waited for it to hurt until she put it in her mouth. Now it's a waiting game, and keep it in the mouth long enough to keep the symptoms at bay, to keep the inflammation down. But if you learn how to use the device, knowing that it is a consistency of the device that's important, nighttime only for the rest of your life, it's very simple. And understanding these concepts, these very simple concepts, make the delivery of the device and protocol very easy, the understanding very easy, and the results spectacular. I say that with experience, authority, and I say it knowing that it sounds unusual for anyone, especially newcomers, who are here to listen about the solution for TMD, the non-surgical solution for TMD. All right, I have made my point for episode number 240 on the usual Tuesday morning. With that said, I would encourage anyone who'd like to know more about this, if you are a provider and would like to join our network of providers who use our patented device and protocol for the treatment of their patients, that information can be seen at urbanektmj.com. I'm happy to be in contact with anyone who'd like to ask me questions or talk about it at tony@tmjservices.net, tony@tmjservices.net. I am open for discussion and even criticism. I'm happy to talk to anyone who would like to discuss what I have discovered about the actual cause of all the symptoms, which is chronic inflammation, and how to best deal with and decrease chronic inflammation to get rid of all of the terrible symptoms that people are dealing with TMD for months, years, and many, many people decades. I look forward to our next episode. I hope I'll pick a topic that is interesting to you. I hope this topic was and is meaningful and helpful to both providers and patients. I am Tony Urbanek, and this is TMD Demystified.